Tanya Patterson. I'm the moderator. This is, of course, Dr. David Markham. He's an experienced heart failure and transplant cardiologist and has performed groundbreaking work in the area of assisted device physiology. He completed his internship and residency at the University of Virginia, a postdoctoral fellowship in clinical and molecular cardiology at the University of Texas Southwestern Medical Center in Dallas, and a fellowship in cardiology with advanced training in heart failure and cardiac transplant at the University Medical Center. Before he returned to Atlanta, Dr. Markham was a medical director of the heart failure clinic at Heartland Memorial Hospital and an associate director of heart failure, assisted devices, and cardiac transplantation at UT Southwestern Medical Center in Dallas. Thank you very much for attending today. I present you Dr. David Markham.
All right, thanks everybody. I think I'm supposed to stand over here so people online can see it. So, how's everybody doing? The kidney room always has the most people, but we have the coolest, right? So, I think we're real proud of GTF. There's nothing like GTF anywhere else in the country. And it's hard to imagine that, but we're real proud of what GTF does to help transplantation patients who are going through that process in the state of Georgia. And so what I want to do here today is give you a little bit of hodgepodge, I guess I should say, given the season of cornucopia, information about heart transplantation, okay? And a little bit of this involves some history, so we'll
1 second, sorry, I forgot to share the media. There we go.
At the beginning here, I want to say that just a couple of weeks ago, I had the privilege of taking care of a patient who we think was the longest current living transplant patient in the history, in our current history. He was about 36 years out from his heart transplant. He passed away recently, so I'm going to dedicate this to him. 36 years with a heart transplant is pretty darn amazing. And it's a real late 70s. Yeah. He got his transplant in his 40s or so.
Australia.
No. Other things I probably would expect. Yeah, real proud that he lived 36 years. It's incredible. So go ahead to the first slide here. Okay, so we're going to talk a little bit about the pre-transplant phase first. And again, this is a wide-spanning range of topics here we're going to hit on. So.
Oh dear. That was not supposed to happen. Okay, there we go. Okay. There we go. Are you showing?
Keep going.
Let's see here. I'm trying to figure out how to turn the camera around. My apologies.
So back in ancient times, heart failure, you may have heard this term, hydroxy or dropsy. These are some ancient pictures, old pictures of people swelling due to heart failure. You can see ascites, a buildup of fluid in the belly. But it basically refers to the generalized swelling due to accumulation of excess water due to a weak heart. Next slide. Bloodletting used to be a thing. Okay, everybody's heard of using leeches. And here's an old picture of leeches in a jar, and also scalpels used for bloodletting. People used to think that this was a adequate treatment for dropsy, as they say. So, and it was said that it is the least equivocal of remedies. Its good effects, when properly administered, are in most cases so immediate and striking. In short, bloodletting is a remedy which, when judiciously employed, is hardly possible to estimate too highly. So, as we know, it's not that great. And so, we've come a long way. Next slide. And so, if you go through the history of heart, you see lots of references to heart disease, heart failure, and so on. This was from the 15th century. This was an early attempt at transplantation, believe it or not. Maybe the first attempt at transplantation. So there's this thing was called The Legend of the Miracle of the Black Leg, described two surgeon brothers who lived in the 3rd century. This picture was from the 15th century, and they tried to put a leg on someone else's leg, and the legend relates their miraculous removal of a diseased leg of a Caucasian Roman named Justinian as replacement of a recently deceased African patient. And so medicine has always thought we could take organs from one person and put them onto another person, going back thousands or hundreds of years. So as early as the 6th century BC, the Indian surgeon Sushruta described reconstruction of facial wound by trying to implant skin and cartilage on someone's face. Keep going here. And in more modern history, so this is just a reminder of where we've come in the last 100 years or so. So the first successful corneal transplant, believe it or not, took place in 1905. In 1954 was the first kidney transplant that was done between identical twins. And then in 1957, azathioprine was developed. This is our real first immunosuppression medication. So next slide. In 1962, our first deceased donor kidney transplant took place. In 1963, Dr. Hardy performed the first successful lung transplant. And then a time that's near and dear to my heart was in 1967, Christian Bernard performed the first successful heart transplant. Do people remember that happening in the news? Christian Bernard was from what country? Yes, you're correct, South Africa. He had trained with the Stanford group, and Stanford really wanted to try to be the first group to do a heart transplant. And he went back to South Africa and pulled it off. And Louis Washansky was the first recipient. If you go back and pull up all these old Time and Life magazine articles from that time, you'll see pictures of this happening. That was in 1967. We've come a long way since then. Go ahead forward here. Yeah, here it is. Yeah, I forgot I put this one in here. So this is the surgery that took place. He was on the cover of Time magazine. Interestingly, Christian Bernard was only able to operate for a few more years after that. He had rheumatoid arthritis. He could not operate throughout his whole career. He was so famous that he began traveling the world, just doing lectures and things like that. But he suffered from rheumatoid arthritis. Forward here. Okay, then in 1981, Dr. Shumway performed the first heart-lung transplant. One of the biggest achievements in all of medicine occurred in the early 80s. It's hard to imagine this is so recent, but cyclosporin was developed in 1983. I was at a meeting recently where the person who did the first studies on cyclosporin was doing a talk about the history of the development of the drug. And then it had been shipped to him from a lab in Europe to the United States. I think they were at, may have been Stanford. I forget which place he was at the time. He reached in his pocket. He's like, I have saved the original bottle that they sent me, cyclosporin, that we used on the very first patient. He had it in his pocket and pulled it out, which was very dramatic and exciting. And so 1990 was when tacrolimus became available. And in 1995, mycophenolate. Keep going here. This has made it possible for all these outcomes, like the patient I mentioned at the beginning, to and modern patients to achieve long-term success. And then you may remember this: in 2005, the first successful partial face transplant was performed. You all remember that a few years ago?
Yes.
So what heart transplantation tries to do is we try to balance the poor prognosis of heart failure as a patient gets worse and worse with heart failure, with in the absence of comorbidities with the risks and benefits of the procedure itself. We don't want to do it too early. We don't want to do it too late. We want to do it at the right time so that we can achieve good long-term success. Obviously, it becomes riskier and riskier to do this type of procedure on someone who has a lot of comorbidities and other problems. We as a whole community, as a medical community, as a society as a whole, we have to be advocates for the recipients. We also have to be advocates for the donors. A donor has to give their life. I always say we turn something really bad into something So, but we have to be advocates for the donor and the recipient and try to use this precious commodity. The precious commodity is a proper term in the best way possible because this is someone else's heart that we're dealing with. So, next slide.
Okay. Come on.
This is what heart failure looks like. This is a very dilated, enlarged heart. Normally the heart should be much smaller than this. Cross section, a wall gets thinned out. The heart doesn't work effectively and it leads to progressive and more heart failure and symptoms of heart failure. Next slide. So depicted here, this is a normal heart beside a enlarged heart due to cardiomyopathy. You might ask what cardiomyopathy means. We use that as a general term for any disease that makes the heart weak. Cardio meaning heart, myopathy meaning weak muscle. Okay, weak heart muscle disease. So, next slide. And this is how it's done. So it's not the most complicated procedure in the world, but some complications can occur with any procedure. We're taking out the heart from the recipient and leaving the connections here where the new heart can be sewn in, just like this. And you're sewing around in rings. I'm not a surgeon, by the way, but I'm a cardiologist. But you make these different connections, the SVC connection, aortic connection, coronary artery connection, IVC gets connected. And then what happens is sort of amazing. The heart gets warmed up. It's usually in I'm going to talk more about this in a few minutes. It's usually in a cooler, cool down, cold, and you warm it up. Your heart starts beating. And then you can unhook the clamps and let the blood start producing through the body. But it's a great thing to see the heart right there in front of you go from being still to beating and helping the patient. So go ahead.
Sorry.
I'm sorry?
I was asking, did it just jump a bunch of slides?
It may have. Let's just double check and see here. Go back a couple here.
Come on. Sorry, it's an older laptop. I apologize. One sec. Let's go. There we go. Okay, here we go. I think that was next. Why are you there?
This is just another picture of the connections that are made during the heart transplant. I'm going to relate to this. Orthotopic means from another person. Okay. We're going to talk about a couple interesting things here.
Hang on 1 second. I'm sorry. That just popped up for no reason. Okay, go ahead.
Next slide. Okay, so heart transplant is treatment for, it is used for treatment of end-stage heart failure. It's important to recognize that we have 2,000 plus or minus hearts in the donor hearts available in the United States each year. So again, it's a precious commodity, and we don't have donor hearts for everybody with heart disease. Obviously, in the U.S., we have millions of people who have heart disease, and so it's estimated that each year about 6 or 7 million people are admitted in the United States to the hospitals with heart failure. And so on the same line, not everybody is a candidate for heart transplant because going back to that little seesaw thing I showed, you have to have the right set of issues, the right set of lack of comorbidities, and those sorts of things to go through this process. So next slide. Okay.
Oh, okay, there we go.
Okay, so we're going to talk about something else here. So back in 2018, a new listing criteria system was laid out. I just want to mention that briefly because it's worth talking about how this works now. I'm going to talk a little bit about what effects that has had on the allocation of hearts in the United States. Next slide. Okay, so in 2018, and UNOS, that is the organ sharing organization, changed from a 3-tier system, high tier, highest priority to lowest priority, to a 6-tier system, 1 through 6, based on urgency for transplant. Okay, The intent was to better stratify patients who are most at risk, reduce waitlist mortality, and enable broader organ sharing. So I'm going to take an aside there, and I'll give you a little bit of a side story about how this works. For hearts, we have to we like for the ischemic time to be less than about 4 hours. That means that wherever that donor is, we have to have the heart removed, transported to the recipient, and then implanted in the recipient within 4 hours. It includes transportation, the flight, ambulance ride, everything. So in the past, that has, and I'm going to say a few things that are kind of cool about this in a few minutes. But in the past, we have been limited by a limited geography. So, for instance, if we have a recipient here in Atlanta, we basically take donors from the surrounding states, the southeast. It's not like we're going to go to Vancouver, Canada, and bring an organ back, and that would be way more time, and the risk of that organ not working would be extraordinarily high. Okay, so there's all these geographies, all these places around the country that are local vicinities where donor organs are taken and implanted into recipients in that area of the country. And so the idea in the new system was for the highest urgencies, to expand that out a little bit. Next slide. And highest priorities went out to about 500 miles. Okay, it's a little bit a broader expansion of that geographic zone than what we had before. And so the listings in this new system for higher priority groups have increased. So it used to be that 25% of patients were at the highest priority in the old system. And with the way this new system works, it's if you consider highest priorities, categories 1 through 3, then that goes up to about 35 or 40%. So it kind of kicks people, and what allows people to have higher urgency in those top tiers. And what this has resulted in the last few years is that the people who are at the highest priority, more hearts are going to those people with the highest priority, from about 70% all the way to 80%. So that's worth thinking about, because 80% of donor hearts are going to the people who are at the highest on the list. Only 20% are lower. And that was the intent. The people who wrote this system designed it that way. Okay, so and what we mean by people who are highest on the list are people who are the sickest people, who are in the ICU with balloon pumps, support, ventilating, things like this, even things like ECMO, which I'll mention briefly. But most people who get heart transplants are in these high categories, is what I want to say. So next slide. So the idea was that transplanting higher acuity patients would happen more, but as you can imagine, it's been carefully studied in the last few years that if you take a lot more sick people, the sickest people of all, and start doing major heart surgery on them, the outcomes may not be as good as before, and we've seen some of that. So in other words, if you're waiting in the ICU and you're hanging on by a thread, going through heart surgery is much different than doing heart surgery on someone who's at home waiting on a transplant. They're healthier, they're not as sick, and those outcomes are going to be a little worse across the whole nation. And we've seen that. We've seen some of that. The early survival after transplant overall has gone down a little bit because we're transplanting sicker people. Did I describe that okay? And so, although the current analysis is conflicting, and this, a paper just came out just recently talking about how this new listing system has affected our outcomes in the last 5 years or so. So data now suggests that it's similar, but maybe a little bit less. And so this has been surprising to us. It was always felt that we would have slightly less mortality. We do see that a little bit, but it's also true that over time, surgical care and ICU care gets better. And so the jury's still out. We really need this over the course of years and years and decades, but we're going to see how this system affects outcomes long term. So next slide here. So Now this new system, we have a lot more people going to transplant, just as I mentioned, who are in the ICU on things like ECMO, which is sort of like being on bypass, balloon pumps, biventricular support. What I mean by biventricular support is that we have machines that sort of are temporary machines that can do the work of the heart for days or weeks. And while someone is very, very sick waiting for a heart. So we have, again, more people who are on these types of machines going to transplant. These devices, and there's something called an Impella device, which is a pretty cool device. It's a long catheter that snakes up to the heart, sits in the heart, has a little motor on the end of it, and pumps blood from the heart to the body. It's not something that people go home with, but it's used in the ICU. And
Similar to the LVAD.
we can talk about LVADs in a minute. This device is what's called a temporary LVAD.
Okay.
And so we have a lot more people going to transplant with these types of devices, is what I want to say. And these devices, according to this recent paper, have shown that if you have these types of things in, then again, we actually have reduced wait list times. So people are waiting a little bit less. But the trade-off is that you're in the ICU, you're sicker, you're in the ICU, and you've got these things in place. Increased rates of transplants and decreased death or deterioration while you're waiting for transplant. So we're transplanting more sick people. People are getting transplanted earlier, and our technology has gotten a little bit better, so that people who are waiting are doing a little better. So we've got a number of interesting things going on here. Our technology is getting better, is what one of the summary points of this is. Next slide. Now we've had decreased use of LVADs because of this new listing criteria as we've described. We have more people who are sicker, who are waiting a little bit longer in ICU to try to get a transplant rather than going to an LVAD. Who knows what an LVAD is? Let's you ask this question. So, okay, so an LVAD is a left ventricular assist device. Because we only have 2,025 hearts in our lifetimes, the scientific community has developed LVADs. These are pumps that are meant to be implanted in the body, and they can stay in for months and years. Okay, and there are some people who just have them until the end of their life. Again, we only have 2,500 hearts, and so people who, not everybody can have a heart transplant, but a lot of people get LVADs, carry around a couple of batteries, have a line that connects the pump that's inside the body to the batteries, and can live a long time. I have many patients right now that had an LVAD about 15 years ago. Okay, now this has rapidly expanded in a short period of time. And even when I trained, which was a few years ago, 15 years ago, the expectancy was often about 2 or 3 years. Okay, in that time, we've had people now living 10 and 15 years. And this technology keeps people alive, and it does quite well. I'm going to show you some pictures in just a minute here. But because of the new listing criteria, we have more people trying to get who are ending up sick, and we're trying to get them a transplant. And at least in the last couple of years, the use of LVADs has gone down. That's going to probably even out over time, because obviously an LVAD does not require taking a heart from someone else. You can go to the shelf, take an LVAD off, and say, "You're really sick. You really need an LVAD. Let's do that now, so we can keep you alive." Okay, and LVADs work pretty well. The current device is called a HeartMate 3 that we use, and if you want to explore what LVADs look like and just learn more about this, I would encourage you to go to the HeartMate 3 website, which is made by Abbott. And there are a lot of really great videos about these devices, and it's worth learning about that sort of thing. So, so my first point is on this slide that with these new listing criteria, we've had decreased use of LVAD, but sorry for my misspelling here. We've had, no, it is spelled right. So we've had decreased or I'm sorry, greater geographic sharing based on that change in the rule to 500 miles in some cases. And so, but we still have a lot of reforms that are needed. Patients with congenital heart disease it's still in the new listing criteria, it's still more difficult for them on average, to get hearts compared to people who do not have congenital disease. And still, I think there need to be some changes with multi-organ listing. So if somebody needs heart kidney, heart lung, those sorts of things, we need to find better ways to stratify those patients on the list to help them out. And so, next slide. Okay, so LVADs are really incredible devices. We would have never imagined 40 or 50 years ago that we could implant a pump in someone and keep them alive for decades, especially without having clotting problems and blood clotting and those sorts of things. But it's still a bit of a problem. For the most part, we've improved technology in amazing ways to make this work. So this is some of the pictures of this. So one of the future of LVADs, this is going to probably blow your mind a little bit. Let me back up and say our current LVADs require a line that looks sort of like a little cord about this big that comes out of the belly, connects to the batteries, and controlled with a computer. In the future, in the near future, we're going to have devices that do not require that they can be charged and run in a totally implanted system that's in the body. The problem with the line that comes out is it can get infected, it can cause problems, it can get nicked, or those sorts of things. We're not going to have that in the future. We're just going to have a system that's totally in your body, and if that's a charger above your couch at home, you just sit here and while you're watching TV, this thing above your couch at home charges your device, and then you get up and you can go for a few hours, and then come back and watch the news and recharge on something that's sitting near your living room. And so those are called transcutaneous energy transfer through coils devices, or TETs. This is the HeartMate 3. This is a device that has sort of fallen out of favor. It's called CardioWest. Everybody always asks about, hey, where are we with just total artificial hearts? Okay, with our current technology, with these other things, we hardly ever have to take someone's heart out completely and then do the work with a one device that does both the work of the right and left ventricle. In fact, we've moved into a time where if somebody has heart failure from both the left ventricle and the right ventricle, we just use two LVADs on them. We leave the heart and we put an LVAD on the left side, we put an LVAD on the right side, and their heart's still beating, and we pump blood to the body and pump blood to the lungs with two LVADs. We don't really need this sort of thing. And these devices have been fraught with a lot of technical problems in the past. Yes, sir.
With that procedure with the two LVADs only be during a hospital stay or service?
It's a good question. A lot of so this is extremely rare, by the way. Most of the time we use LVADs, left ventricular assist devices, and that's sufficient. I've had a few patients who have needed an RVAD, and those are usually really, really sick people. I have gotten a couple of them home for a brief time. The idea is still to try to transplant those patients as soon as possible. But a lot of those people, depending on how sick they are, stay in the hospital. So we're talking really sick people who we're trying to keep alive until they can get a heart transplant. And so, I texted one of my patients. This is another side story. One of my patients who I've taken care of for 10 years yesterday got his transplant. And so I texted him a few minutes ago. He said, "Hey, how you doing?" And so I was checking to see if that was him, but it's my wife. He's doing great. He's doing great. So, next slide. So again, so with heart transplant, what you're doing is you're replacing the heart. You're taking someone else's heart and putting it in that can be at risk for things like rejection, infection, and that makes all these medicines that we talked about very important. The immunosuppression regimen like cyclosporin, Prograf, and so on. It requires ongoing immunosuppression. There are potential problems. There are psychosocial side effects of being this sick and needing a heart transplant. We have folks on our team who are psychologists and social workers who really help patients and their family through this. And LVADs have completely different sets of problems, okay? An LVAD requires blood thinning, which we have a blood thinner, so we don't have a clot buildup in the pump. We are in a current setting where we have drive lines where batteries are attached to the LVAD. Again, we still have psychosocial effects of this sort of thing. If somebody has an LVAD that starts having a problem, it's a lot easier to take that out and put another one in versus trying to get a new heart transplant. So again, it's just a slide saying we have different benefits and risks of both of these different options, okay? But they both work pretty well. And I should say that although a lot of patients with LVADs do well for a really long time, we have not quite approached the long-term survival compared to heart transplantation. If you take the average, if you take a whole nation, and take everybody who has had a heart transplant, the average time of survival is about 12, 13 years. It's pretty good given that a lot of people who would not have received a heart transplant would not be alive. And again, we see a lot of people who live a lot longer than that. We see a lot of patients with LVADs who are starting to get up into that many-year category and approach that. But as we get new technologies on LVADs, we're going to do better and better and better and have more options. So we're all optimistic about this. Go ahead. Okay, so let's talk a little bit about the post-transplant side of things. So patient education is really important post-transplant, okay? So we want people to know about their medications. We have the transplant nurses and the coordinators really involved with the patient and their family to answer questions and take care of any problems. We usually have a transplant dietitian who helps people with their nutritional questions and needs. We make sure that people know who to call, where to go, what to look for. We often do rehab and those sorts of things. And GTF is involved with support through these sorts of things with things like what we're doing here today, but also things like people who need financial assistance and those sorts of things, support for families. When I first started doing this in training, I didn't quite understand, the full psychosocial effects on caregivers and family members as I quickly learned in the transplant area. It's hugely important. So all centers, especially our centers around Atlanta and Georgia, do a great job with supporting not only the patient, but family members, spouses, caregivers, other family members. We spend a lot of time answering questions of people's children, and what this means and those sorts of things. So next slide. When someone donates a heart, that is done anonymously, okay? But what people are able to do as a recipient is through UNOS, not through GTF, but through UNOS. If someone wants to write a letter of thanks to their donor, they're able to do that. And some people might hear back from their donor family, some people may not. But I have had that happen many times before where eventually those families connect. A few years ago, I had one of our recipients wrote a letter to their family, and they had lost their teenage daughter. Their daughter was a donor to this person, and they wanted to come and meet the recipient of their daughter's heart. And so we met in a room, they hugged each other, and then they got to listen to their daughter's heart right in their chest. And it's incredibly moving to have that happen. And oftentimes these families become lifelong friends. And they're grateful that they can help someone. And again, we're taking something that's bad and trying to make it good. Post-transplant, there are a lot of visits. There are a lot of echoes, taking pictures of the heart. There are a lot of EKGs, there are a lot of lab tests, those sorts of things. And for heart transplant patients, there are a lot of biopsies. Okay, so next slide, I think this is the next one. So we have to watch for rejection, okay? And so the way we do that is we snake down this little thing called a bioptome from the neck up here down into the heart and take these little tiny specimens of the heart. And the pathologists look at it under the microscope, and we look for any signs of rejection. About 30% approximately of people in the first year after a transplant will have some sort of rejection. Most of it is you never know it unless we were looking for it, if you're asymptomatic, in other words. And that's treated by adjusting immunosuppression, which is most people do really well with just changes in the medicines. We have to watch for that very carefully. But this is how it's done. So this again, here's this. And this takes about 2 minutes, by the way. So you snake this down to the right ventricle here, and it's like a little pair of tweezers or pinchers, take a little tiny piece of the heart. And on average, about in the first year, depending on the center, there are usually about 20 or so biopsies that are done in the first year. And then it becomes less common as people go forward, to the point where eventually people who are 5, 10 years out or more are having very few, if any, biopsies. Most of the worry about rejection occurs in the first year or two. So,
Okay, when look for rejection, look for the white cell count in the tissue.
I think I paid you to ask that question. So there are types of rejection. One is the kind you're talking about where lymphocytes invade the heart, and you're looking at what we call cellular rejection. That's the most common. Okay, so we look at it in the microscope, we see if cells are attacking it. But there's also, that's called acute cellular rejection. There's also something called vasculopathy or chronic rejection, where the heart arteries become narrowed over time. And there's also called antibody-mediated rejection, where antibodies, the body starts making antibodies. And those, we look for those in a variety of different ways, by looking at the pathology, doing blood tests to look at the recipient and see if they are making what are called anti-donor antibodies. There are tests for that. But the key thing is people do a lot better if they take their immunosuppression. If people start not taking their immunosuppression or doing things they're not supposed to do, then the risk of rejection goes way up. So you're going to ask something.
Yes, after you had 100, after the year, you still get a biopsy, don't you?
Right, yeah.
And that's how often.
They start becoming, every center is different, but it starts tapering down years 2, 3, 4, 5 to 10, and so on. And so,
So you were saying about rejection go up if you start missing the medicine?
yeah, you have to take your medicines. Yeah, we encourage everybody to take their medicines, because missed medicines come along with a higher risk of rejection. Each of these kinds, okay? So, but there are different types of rejection, is my point, and we have our ways of watching for them. And as far as heart artery, the coronary artery narrowing goes, that's why we do also left heart caths every year or 2 or 3 or 4 years to look at the heart arteries to see if there are any narrowings in the heart arteries. Okay, that's related to this.
The narrowing of the arteries.
It's a type of rejection.
Yeah.
Yeah. But it also means also goes along with garden variety things like controlling diabetes, controlling blood pressure, and eating healthy and living healthy. And so we like for those things to be really, really well controlled.
So it can occur after your 5 years of transplant.
Yes.
Post-transplant.
Yeah. But the risk starts getting way lower as far as people get out. The risk of rejection is way different at 10, 15 years than it is in the first 1 or 2 years. So that's good. It's a good thing. Next slide here. So risk of rejection is highest after surgery. So so 40% of people had 1 episode in the first year or so. But the treatment for this is usually, depending on the type and the severity and so on, of adjusting medicines. Did you have a question? Or? Next slide here. So what we're trying to do here with immunosuppression for heart transplant patients is balance risk of rejection versus infection, because obviously we're affecting the immune system. People are more prone to things like viruses, infections, and things like that. Things like CMV, which is a type of virus. So we're really watching for that. And oftentimes people will be on medicines to protect against infection as well, like bacteria.
So explain that CMV rejection, viral cause rejection. Is that something that's very common? CMV.
It's fairly common, yeah, this is a whole topic in and of itself.
Right.
But I'll say that CMV is a type of virus that's out in the world. Most of us have had CMV. But it's worrisome for an immunosuppressed patient because it can cause a lot of problems. It can cause pneumonitis, it can cause cerebritis, it can cause inflammation of the gut, it can cause febrile illnesses, where you're running fever and you get really sick. It can affect the bone marrow. It can affect a lot of things. And so it's one of the things that we worry about. And so if you hear your providers talking about CMV, that's what we're talking about. Now, one thing that's worth talking about is, just I'll mention this briefly, is that some of us have not had CMV, so we're what we call CMV negative. And so if you're CMV negative, you go into transplant, you don't have the protection of having had CMV in the past. So we watch those people especially carefully. If you've never had CMV, you don't have CMV antibodies, we watch that very, very carefully. Okay. That's a whole topic in and of itself, but that's all I'm saying. So, who's heard of you? Sounds like you've heard of this, right? So
Right.
people talk about CMV. So, okay. Next slide here. So, we watch out for cancers. We watch out for osteoporosis because people are on steroids and that can affect the bones. Hypertension is very important, like along with diabetes and so on. We watch for mood, anxiety, depression, those sorts of things. And like I said, diabetes here is very common. We like for people to get their flu shots. One of the last slides I have in almost all my talks is a Van Gogh painting of Vincent Van Gogh suffering from the flu, and it just reminds me that, hey, we should all get our flu shots, especially if you're not immunosuppression. So next one here. So the first year is intense. A lot of things go on, and if people are, usually within the first few weeks and months, if somebody is able to go back to work, we like for that to happen so they can support themselves and their family and so on. But there are a lot of visits, a lot of things go on. Next slide. Let me see what time we got here.
10:22.
Okay, we're gonna speed up here. Go ahead, and I'm gonna talk about a couple of things. Keep going. Okay, so I want to show you a couple of cool things before we stop here. So we talked about geography of moving a donor from a distant place to a recipient who's in a local place, like a donor, for instance, who's in Virginia and the recipient's here in Atlanta. That's fraught with a lot of danger because that heart could have things happen to it while it's sitting in a cooler. The time could be longer. It could not work very well when it gets here. But we have some new tricks. This is called a transmedics device. This is the donor heart here, and it's hooked up to a system that pumps blood through the heart and keeps it beating the entire time it's out of the body, and it keeps it warm. It's not cooled down. It's not in a cooler. If I could show you a live video of this, you would see that this heart is in there going like this. Okay, and it's brought in, unhooked, put in the recipient. And we've seen some good, this has only been used for a short time, but we've seen some good outcomes with this. It's a really interesting device. I wanted to mention that here. If you want to learn about this, you see some cool videos, really cool videos. Go to Transmedics and you'll see some stuff here. Next one. This is another device by Paragonics, and it's a different configuration, but it's the same sort of thing. It looks like a cooler, but this heart is in that device, warm and sort of perfused by oxygen and blood and that sort of thing. So check out this website as well. It's pretty interesting. Next slide. Okay, so last, I'll leave. Who has heard about the couple people who have gotten pig hearts? Okay. What have you heard? What have you heard about this?
I got a pig valve.
Let's see.
I got a pig valve.
Yeah, so
But that
that's been around for decades.
Yeah, mine got hers in 85.
Anything, it still cost me to get them stuff.
Yeah. This is an actual pig heart. So what they've done at the University of Maryland is genetically engineered pigs that have genes modified, and I think it was about 8 or 9 genes. I forget the exact number. these are anti-inflammatory or pro-inflammatory autoimmune type genes that to try to make that heart compatible with the recipient. The first one was done several months ago. The person lived about a month or so. And now the second one has been done. You're going to see this on the news. This is the guy right here. This is at, and I just got this off of CNN a few days ago. He's still alive. He's at the University of Maryland. And there are no signs of rejection so far. I think this is going to be, it's been about a month. Yeah. Next slide.
You got a full big heart.
This is there it is right there. So this is the pig heart, genetically engineered pig heart. You can't just take a, right, it would reject immediately. But the key for the future is to maybe find the right set of genes that make rejection a lot less likely. This is going to undergo a lot of study in the future, but at least this is sort of like Christian Bernard doing this in 1967 on a guy who was really sick. This patient, by the way, was not a candidate for a regular. He was a little older, he had a lot of comorbidities. He was willing to take the chance of trying this. And this is probably something that's going to get better in the next 10 or 20 years as we find ways to genetically engineer whole organs. Now, there's also this whole area of study, which I've been involved with, of being able to grow, maybe use the right word, or just design or 3D print parts using your own stem cells. Okay, that's also a thing for the future. But I wanted you to see that the guy with the second living genetically engineered pig heart is alive right now today. So, next slide. So we only have a couple minutes. I want y'all to have a little break here before we get back down. So I hope hopefully that was sort of interesting. It's a pleasure for me to meet you. And are there any questions? Yes.
Have you heard of somebody getting a heart transplant and a thymus transplant?
I have not seen that.
I'm in a support group with other parents who have kids with heart transplants, and one of them was saying they were talking about replacing the thymus so that you might have to take immunosuppressants. Is
That has been something that's postulated for a while. I think that is not really taken off. So I don't think there's a lot of literature on that either. Good question. Yeah. Well, thymus is related to immune response. So, yes, sir.
Have they fully started using DCD donor hearts yet?
Yes,
They're implementing more now.
that's right, especially with these devices like the Transmedics devices and that sort of thing. So I recently was at Emory now working with P9, and the centers around Georgia are doing that a lot more. That's right. Yeah.
One question, so if a person have congestive heart failure and they have something going on with their liver, don't the doctors tell them that they need a liver transplant as well as a heart, or does that keep you from getting on the waiting list if you have both issues?
That's a huge topic, and that's going to involve a lot of very specific questions about that patient, what the disease is, and that sort of thing. So having a heart liver is pretty rare, but can be done. Really related to specific instances for the patient. I don't want to speculate.
A heart transplant, she could be on the list. She was about as sick as I was, but they didn't say anything about the liver. But I can tell that she needed a liver because of her eyes.
I can't comment. Yeah. So sorry, but
Yeah, how about the supplements like vitamin C and D, lycopene, and arginine?
Yeah.
They help.
not really, not really. So vitamin C, this is a day-long topic in itself.
Right.
Short answer is that most supplements are not shown to be helpful. Vitamin C was originally speculated to be helpful by Linus Pauling, who you may have heard about in the 1950s. Thousands of studies, it's neither here nor there, doesn't really do a whole lot. L-arginine as a nitric oxide donor hasn't really shown to be that helpful, even in people who have rheumatologic diseases. And so, if you look at the AHA guidelines, and other guidelines, don't really recommend supplements. Again, that's a whole other topic. That's probably all I'll say about that.
Yep, I got another question. Come along with it. Excuse me. That on the stenosis of the arteries, is that the leading cause of rejection?
That's so if we look at why transplant patients eventually die, a lot of it is not related to the heart, okay? A lot of it is aging, things like cancer, things like kidney disease.
Yes.
You know, you have things that a lot of other people have as they get older, strokes, unfortunate things. But there are things that are related to the heart. That's one of them, is narrowing of the heart arteries over time. It can occur over decades. That's something that we watch for.
I still don't know the reason for that, is it because the heart is pumping too much with it?
No, we call it chronic rejection. It often goes along. This gets very complicated. It goes along with what we call humoral rejection in some cases. But we do have special immunosuppression agents that we know slow that risk of it's called vasculopathy.
Yeah.
That slow that down. And so we know that we can treat that in some way. I've seen a lot of patients do really well once we adjust to immunosuppression, where that form of vasculopathy sort of subsides or stabilizes and that sort of thing. We've come a long way in the last 30, 40, 15 years. I mean, they've come a long way. And so, I'll ask some great questions. So,
I talked to several heart transplant recipients. One told me that he had a viral attack on his heart, it destroyed his heart. Several people told me that. A virus attacked the heart. What kind of virus?
Almost all viruses can do that, especially flu, COVID. Everybody's seen the news during COVID time. That's what that is. That's a viral myocarditis. A virus affects the heart. But any virus can really cause damage to the heart. So that's why when we use this is worth repeating. And when we use the term cardiomyopathy, that is a big term. It involves things like viruses, things like hypertension affecting the heart, genetic causes of having a weak heart, and about 1,000 other things. And so there are lots and lots of reasons, but including things like viruses that can affect the heart. So, we'll stop here so everybody can get a bathroom break. Okay. Thank you for being here today. Thank you for your questions. It's a real pleasure. We may cross paths in the future as we go forward. I hope I can be helpful. Your teams and your carrier providers. We have a great team of folks all across Georgia. We all work together really nicely. And so best of luck, and let me know if I can answer any questions in the future. I'm leaving town right now, but have a good Saturday. So thank you.
Thank you so much, Dr.
Thank you.